Hello, today we are going to teach about IMHA. We will discuss how to read graphs related to immune-mediated hemolytic anemia, or what we call in Thai, the condition where the immune system destroys red blood cells. In fact, diagnosing IMHA does not necessarily require flow cytometry or performing a DAT. If we have a good enough blood analyzer, or if we have graphs from scattergram or impedance, especially the older impedance, they can indicate IMHA quite well. As we know, the DAT test is a standard method to check for IMHA or cold agglutination. During cold agglutination, there is precipitation of red blood cells, known as agglutination. Agglutination conditions can be divided into two types: warm agglutination and cold agglutination. Cold agglutination is significantly harder to treat than warm agglutination. The mortality rate for those with cold agglutination is higher. In the picture, we can clearly see how red blood cells look when they break or precipitate. This is on the first day of IMHA occurrence in this dog. Typically, every case will show red blood cells with this appearance when cold agglutination occurs. It is recommended to keep the animal in a warm environment, ideally above 28 degrees Celsius. For warm agglutination, it is advised to keep the animal in a cooler place, around 23 to 21 degrees Celsius. Before learning about IMHA, let's review blood test interpretation. Starting from 7 days before the occurrence of IMHA, let's take a look. The first thing we will see in a normal condition in animals is the WNR section. Here, there is a lower line on the horizontal axis labeled 1, 2, 3, 4, 5. Normally, in healthy animals, white blood cells do not exceed the 3.5 mark. When we look at the WDF section, we can see the occurrence of S lymph and L lymph. Noting the color differences between the left and right, indicating the quantity of S lymphocytes and L lymphocytes. When we see monocytes sharply rising with dotted points along the x-axis, this is a warning sign of autoimmune, blood parasites, or viruses. In the reticulocyte section, what we see is related to red blood cells, which typically are on line 3 in the Sysmex exon system. However, for the IDEX ProCyte DX blood analyzer, it would be on line 6. The midpoint here is called RBC, showing no significant rise or fall, quite steady. The green section is referred to as IPF, or the immature platelet fraction. This case still looks good. Normally, white blood cells should range from 6,000 to 17,000 in dogs. For red blood cells, I classify them into two categories: RBCI and RBCO. RBCO refers to optical, while I stands for impedance. In this section, RBCI is at 7.2 million, with the normal range being 5.5 to 8.5. RBCO will have the same value, but it is measured in the research section, providing more precise accuracy than impedance. Therefore, in current research related to blood, we primarily use RBCO rather than RBCI due to the latter's considerable variability and several influencing factors. These include fragmented red blood cells, high MCHC, or certain conditions that cause RBCI to measure inaccurately, which I will explain later. As for hemoglobin, or the oxygen carrier, the normal range is 12 to 19. For packed red blood cells, the normal range is 35 to 55. Let's look at MCV. Typically, if MCV is below 60, it indicates iron deficiency. If it's above 77, it indicates a deficiency in folic acid or B12. MCV is measured in femtoliters, representing the volume of hemoglobin in a red blood cell, essentially the average volume of hemoglobin. For MCH, the normal range is 21 to 24, measured in picograms, which denotes weight. Thus, when we divide MCH by MCV, we get MCHC. This means we're comparing the weight to the volume of hemoglobin in a red blood cell. Generally, if it exceeds 36, it suggests the red blood cells may be lysed. Most cases of red blood cell lysis are due to the dog's stress rather than external factors like alcohol application. For platelets, I use the platelet F value, which can be measured in three ways: I, O, and F. I stands for impedance, O for optical, and F for fluorescence. Fluorescence provides greater accuracy and helps derive the IPF or platelet F value. In this case, the dog has 164,000 platelets. First, it's essential not to memorize standard values like a dog's normal platelet count being between 200,000 and 500,000. Each animal has individual normal values for red blood cells, white blood cells, and platelets. To determine if a platelet count is an individual normal value for a specific dog or cat, we look at the IPF. If the IPF is above 5%, the observed platelet count isn't the true count. The true platelet count is higher. However, certain autoimmune conditions can increase IPF, indicating that the platelet count isn't reaching its expected level. For RDW, we typically look at the CV more than the SD. The CV should not exceed 16%. If it exceeds 16%, it indicates increased variation in red blood cell size. If it exceeds 18%, there's a risk of shock or other dangers. Regarding platelet distribution, as mentioned, the graph appears relatively flat, making it difficult to measure platelet distribution. However, it's essential to note that some blood test machines have a technique that can lead to misdiagnosis, as they draw a line to indicate the position and corresponding PDW value. In reality, it should state that PDW cannot be measured accurately. The normal MPV range is 9 to 13, or possibly 5th August 2013. In this case, an MPV of 12.5 indicates that the platelets are relatively large. Similarly, platelet O should not exceed 40%. This all aligns with the platelet kit results, where the large MPV approaching 13 results in a platelet kit value of 0.22. For white blood cells, if we break them down into neutrophils, lymphocytes, monocytes, eosinophils, and basophils, we see that the neutrophil count is still below 10,000 cells. This means there is no inflammation in the body. For lymphocytes, the normal range is 2 to 5. Although this case is slightly high, it can be interpreted in two ways: either an acute infection or the animal has a habit of licking and chewing. This helps differentiate the animal's behavior. Now, for monocytes, the normal value should not exceed 1.0, or in percentage terms, 3 to 10%. This indicates that there's been some abnormality for a while, but not exceeding 7 days. For eosinophils, the value should not exceed 0.4, but can be accepted up to 0.8. Therefore, in this case, we disregard it. Basophils can be accepted up to 0.03. In this case, it's borderline between infection and no infection. Generally, I do not rely much on the percentage side of the white blood cell count. We primarily look at the absolute values, which provide more detail. We only consider the percentage side if the overall white blood cell count is very low. The reticulocyte count here is 0.22, with a normal range for dogs being 0 to 1. This indicates no red blood cell production yet, meaning there has been no significant blood loss, or if there is, it's minimal, and the bone marrow has not yet responded. Reticulocytes are divided into 3 stages: H, M, and L. H stands for high fluorescent reticulocytes, L stands for low, and M stands for medium. IRF stands for intermediate reticulocyte fraction, which is calculated by adding H and M together. If this combined value reaches 40, it indicates a response and a chance of regeneration. The reti value is 25.3, with a normal value of 23. RBC is similar in meaning to MCH, but we use the reticulocyte channel to calculate RBC, which makes it more accurate than MCH. So, if we look at the RBC value of 23.3 and compare it to the MCH value of 22.1, we can see that these two values are quite close to each other. Essentially, they represent the same thing. The difference lies in the measurement method used. If I take the RET-He value and subtract the RBC-He value from it, we get a value called delta-He. This value is very significant and important because it can indicate inflammation or an iron deficiency. It is a very good parameter for diagnosis. The delta-He value is closely related to RET-He and RBC-He, as well as being significant for assessing iron levels and inflammation. Let's talk about IPF, or immature platelet fraction. This value is very important and has been used for about 5 years now. It can indicate conditions such as autoimmune, platelet loss, or the production of immature platelets. Nowadays, it can be used instead of bone marrow aspiration. When we examine it, we always look at both the absolute and percent sides, because if the IPF percentage is high, it suggests bone marrow suppression. Conversely, if the absolute value is very low, such as below 3 in dogs, it indicates potential bone marrow damage or failure. Regarding HFLC, we currently have 2 types: the general HFLC and the HFLC in the WNR channel. Typically, HFLC is found in cases of viruses, cancer, blood parasites, and autoimmune diseases. The HFLC in the WNR channel is an extension to increase the value when the graph is maxed out. The acceptable HFLC in the WNR channel is up to 0.10. If it exceeds this, it indicates the presence of antigens or something that stimulates more lymphocyte staining, correlating with the WNR channel explained earlier. IG stands for immature granulocytes. If IG is not present, it means the body can manage the current condition well. NRBC should not be found in healthy dogs. If a machine detects a lot of NRBCS, it indicates a malfunction, as it might be incorrectly counting lymphocytes as NRBCS. Next, the value of delta-He, as mentioned, is obtained by subtracting RBC-He from RET-He. If the delta is positive, it indicates that the dog appears relatively normal. On the other hand, if the delta is negative, It may indicate inflammation or an iron deficiency. However, a more accurate indicator is the RET-Y value, also known by some as AMR or mean reticulocyte volume, which has a normal range of around 150 in dogs. Next is the TNCN value. TNC stands for total nucleated cells. This value is calculated by adding NRBCS to white blood cells because standard blood testing machines cannot differentiate NRBCS and count them separately. Instead, they combine white blood cells with NRBCS and present the total as white blood cells, but the correct term should be TNC. Following that are the hyper-He and hypo-He values. In this case, the hypo-He is notably lower than 1%, registering at 2.7%. This suggests that we need to be cautious about potential iron deficiency. However, looking at the overall picture, there doesn't appear to be an iron deficiency, indicating we should examine the kidneys for potential issues such as cysts, stones, or other abnormalities. Presently, hypo-He is used by renal disease organizations as one of the diagnostic values. Personally, I can say that hypo-He is more accurate than SDMA, creatinine, and BUN. Hypo-He is superior, but it is still not widely understood. Moreover, hypo-He also relates to iron deficiency, so multiple values should be considered in the diagnosis. Next are the values for S lymphocytes and L lymphocytes. S stands for small, referring to smaller cells, and L stands for large. L lymphocytes include cytotoxic T cells or NK cells, as well as plasma cells. In healthy dogs, S lymphocytes are always more abundant than L lymphocytes. However, in cases of severe inflammation, allergic reactions, or infections, L lymphocytes may outnumber S lymphocytes. Next is the FRC value, or fragmented RBC. Also known as schistocytes, this value should not exceed 0.03 in dogs. If a case has a high FRC, it indicates red blood cell fragmentation, possibly due to autoimmune hemolytic anemia or inflammation. Small blood vessels supplying small organs, tumors, or inflamed areas can cause higher red blood cell fragmentation. The final value is CTC, which stands for circulating tumor cells, and SIC, which stands for severe infection cells, which stands for severe infection cells. These values are derived from the DNR channel and indicate the likelihood of cancer or severe infection in the body. The diagnosis using SIC must always be combined with the HFL-CDNR value. Using it alone can lead to diagnostic difficulties. Typically, if a dog has significant inflammation, both the CTC-SIC and HFL-CDNR values will be elevated. In cancer cases, both values CTC-SIC and HFL-CDNR will be high. In reality, interpreting IMHA results is quite simple when we look at the graph, especially the impedance graph. Can we use the scattergram? Yes, but it is more difficult and requires more experience. Let's take a look at the first day of IMHA occurrence. The advantage of this case is that it started on the first day, May 1st, 2022, making it easier to observe various results. What we need to do now is examine the graph first. In the scattergram graph, if you see this graph, you will notice that the white blood cells are moving to the right. This movement to the right indicates staining with fluorescent dye. Therefore, what you will observe is that the movement to the right and the fluorescent staining indicate that there must be inflammation occurring in this case. Now let's look at the WDF graph. What we see is the relationship between S lymph and L lymph. Do you see that the colors for S and L are almost the same? So, we need to examine the S and L values. Let's take a look. For S lymph and L lymph, we see values of 2.01 and 1.99, respectively. This means they are almost equal. Normally, S lymph should be higher than L lymph in normal cases. Let's continue examining the graph. Particularly the platelet F graph. What we see is a significant amount of IPF, which is represented by the green section here, the immature platelet fraction. In the reticulocyte graph, we can see that normally, for a healthy dog, the RBC would be at line 3, or equivalent to line 6 on the Interpret DX. But in this case, do you see where the center point is? This indicates a condition known as hypoE. Do you see it? And what do we find here? We find fragmented RBC in this area as well. Let's look at the graph further. The simplicity of interpreting this graph makes it easier, but this case is slightly more complex. What we observe is the tail of the RBC curve rising. It does not drop to zero. The platelet graph shows a similar trend, with a rising tail at the end. Let's look at the numbers. As mentioned, we started on the first day. As a result, this dog has only 1.74 million RBCs left. If we look at platelet O, it is at 2.01 million cells per microliter. The platelets are starting to disappear. When RBC decreases, what happens? RDW increases, right? If you remember, RDWCB should be less than 16%. But in this case, it is 20.1%. This indicates a significant distribution of red blood cells, meaning we should look at the reticulocyte count to see if there is any production happening. For the reticulocyte in this case, it's located in this area. It still seems like there is no production, right? Because the normal range for reticulocytes is 0 to 1.5. However, when we look at HML, we find that the IRF value is higher than 40%. The RetHe is 24.3. And when we subtract it from the RBC-He, we get a positive delta value. This indicates that this dog still looks good, even though its red blood cells are only slightly over 1 million. To summarize, why is the RDW higher than normal? The answer lies in the RBC graph. As mentioned before, the tail of the graph is raised. Therefore, when we measure at 20% of the height, we find that the width is increased. In this case, it means there is a possibility of rouleau formation, indicating chronic inflammation or cold agglutination. Now, let's look at the platelets. The platelet count has decreased to only 100,000. When the platelet count decreases, the first responding value is the IPF. Let's take a look at it. Let's continue with some new values. What we see is the CTC, HFL CWNR, and RET-Y. The CTC corresponds with the WNR graph above, indicating inflammation. Normally, the CTC should not exceed 0.05, indicating that this dog has inflammation. For HFLC, or high fluorescent lymphocyte cell, on this side, it should not exceed 0.03. On the other hand, it should not exceed 0.10. This suggests that there is an issue with some antigen stimulating the dog, or it could be an autoimmune response. As mentioned, the IPF can also indicate autoimmune issues. Let's look at the NRBC, which is starting to appear. Normally, NRBC should not be present in healthy animals. NRBC may appear if the spleen has been removed, there is excessive red blood cell production, exposure to toxins, liver issues, or blood parasites. The next thing we see is the graph for hypohe, which should not exceed 1.0%, but now it has increased to 9.0%. We also see fragmented red blood cells, or FRC. This value should not exceed 0.05 in dogs, but this case shows a significant amount. This is why we mentioned earlier why there is a high number of fragmented red blood cells, known as FRC, because this is the pattern of IMHA. Let's look at days 2 and 3 after IMHA symptoms appear. The first thing we need to see is the WNR channel. As I mentioned earlier, it should exceed the 3.5 mark here. You can see it in channels 1, 2, 3, 4, and 5, with 3.5 being significant. When we see this graph, even on the IDEX machine, what is happening here is HFLC, but it should be observed in the WNR channel. Day 2 will be similar to day 1, because when the body loses blood, it takes about 3 days for the bone marrow to respond by producing immature platelets and starting to produce immature red blood cells or reticulocytes. Moving on to day 3 of IMHA, we begin to see what happens here. It's called NRBC. Because NRBC starts to appear, we will see the graph for S-lymph and L-lymph channels with almost the same gray color. What is the significance of this? As I have taught the RBC channel, see here, the tail rises clearly. This is the juncture of the platelets and RBCs, which is the same position. Has this raised part exceeded 5%? If it has, we consider 2 things. One is cold agglutination, and the other is rouleau formation. Let's look at the NRBC value. You can see that the NRBC is now significantly increased. This is quite clear. You will notice that S lymph and L lymph are present. Now, what has happened to S? It is lower than L. We see a high HFLC value in this channel and a high CTC channel value because the body is still adjusting. If we look closely, we can see that RetY is starting to decrease, indicating that iron deficiency is beginning. From this point, let's move on to the next day, but quickly. Let's summarize that if we see the RBC tail rising more than 5%, it indicates two possibilities. 1. Cold agglutination, which is found only in IMHA cases. In IMT cases, this does not occur because it is warm agglutination. The second possibility is rouleau formation, which happens in cases of chronic inflammation, causing red blood cells to stack together and form rouleau. Look at days 4 and 5. What we will see is an increased presence of NRBC. Or we might notice that the RetY value decreases as the animal begins to become iron deficient. We will see higher FRC values. The significance lies in the next point. What we will see is an NRBC pattern that we call bimodal. Or some may call it dimorphic. What does this mean? It means that there are two peaks of red blood cells, or in simpler terms, there are two populations. When reading the graph, we read from right to left. So new cells will appear from the right and move to the left. This indicates that there are new iron supplies and old iron in red blood cells that are not uniform in quantity. If you can read the graph well, you will clearly see that there are two distinct groups in this section. It's essentially the same thing. What happens after 3 days, from the 8th to the 11th? You will notice that the RBC graph starts to take shape and looks much better. You can see that S lymph is now greater than L lymph. If you understand the graph, you will see that in the front part, the color of S lymph is more distinct or greater than L lymph. This type of graph helps us understand what we can see in cases of IMHA. It follows the trend shown in the graph. The trend of HFLC is quite clear, but the more distinct one is the HFLC in the WNR channel. RetY is also very important, but many people do not understand it or have never tried using it. Once you do, you'll find it is a very interesting value. FRC is the same because FRC is very important and helps us diagnose using the scattergram quite well. However, many people still do not fully understand it. How do we know if we only have the scattergram graph? For machines like the ProCyte DX, which do not have the impedance graph, how do we interpret it? According to the image, the first thing we need to look for is the number of broken red blood cells which occur around this area. You will see that the overall red blood cells are elevated. This is because, as mentioned, it is a condition where MCHC can be quite high, or there may be varying RDW values. The condition known as cold agglutination will occur in this area, causing an elevated pattern. In cases of IMHA, there will be a significant production of reticulocytes. This is their pattern. And there are usually quite a lot of NRBCS as well. Therefore, for those analyzing the scattergram, the first important thing to note is the FRC. There is a significant production of reticulocytes, but they still cannot become mature red blood cells because the FRC is high. No matter how much you regenerate and produce, if you cannot reduce the FRC, the production of RBCs will be relatively low or below normal. When this happens, NRBCS will appear. Why should we use RBCO over RBCI? Currently, there are still only a few machines that use RBCO, but it is much more important and accurate. For example, in this case, RBCI measured only 0.86 million cells, whereas RBCO measured 2.99 million cells. The correct answer is RBCO, and RBCI is incorrect. These cases have a very high MCHC. When MCHC is very high, it leads to red blood cell fragmentation. When this happens, machines that use impedance for counting will have significant errors. What should you do if you do not have RBCO? The simple method is to centrifuge for hematocrit. The hematocrit value is crucial, but when examining hematocrit, the veterinarian must first know whether the MCV is normal. If it's too large, the hematocrit value will be abnormally high. If it's too small, the hematocrit value will be abnormally low. Therefore, in truly normal cases, hematocrit should not be used to diagnose diseases. Instead, the number of red blood cells in millions should be known. That concludes the diagnosis of IMHA in dogs. Thank you for listening. If you have any questions, feel free to ask. Goodbye.